Hello, a very good morning. Hi Kishore, a very good morning. So let's begin with our class for today, and today we'll be discussing a few mixed bag MCQs. Before that, I would like you to know about the NEET PG free test calendar. Okay, these tests are completely free. The test which is upcoming is today at 11 a.m. It's a NEET PG 2022 subject-wise test series 2, and it will be dealing with surgery. Then tomorrow you have a test at 7 p.m. and it's an educator curated test series which is radiology by Dr. Nikita Nandwani. Then on March 31st at 4 p.m. you have previous year PYQ test series, that's a mixed bag 5. So everyone who are preparing for the NEET PG 2022 should take advantage of this. This is completely free through Unacademy. Also, NEET PG students, please be aware that there is something that is called as Unacademy Lite. Okay, so what is this Unacademy Lite? It's basically a NEET PG test series. So in this, you will have more than 450 practice tests, which includes subject-wise test series for all 19 subjects, system-wise test series, full-length mock test papers, previous year's question papers, test series which are curated by the top educators. So basically the advantage is you read up a topic or you read up a system, okay, completely thoroughly, and then you have complete evaluation of your knowledge through a test. Okay, so it will completely consolidate your preparation as well as help you very well in your examination. So everybody who is appearing for NEET PG should take advantage of Unacademy Lite. So here there are these 90 plus grand tests which include those for NEET PG, INI-CET, FMGE as well as grand tests and PYQ series will be available. So definitely a worthwhile thing. Now, especially for people who are in their MBBS, okay, and who will be appearing for their NEXT examinations, there is a very beautiful protocol which has been set up by Unacademy. So in this particular this particular course, you will have an in-depth comprehensive concept coverage, because conceptual learning is very important for cracking MBBS, right? There'll be clinical integrated sessions, so this is going to be very useful for your practical examinations as well as when you are treating the patient's life. There'll be answer writing guidance sessions which is going to be very useful for theory examinations. There'll be subject wise tests which will be held every Saturday, followed by discussions on Monday. Okay, so that is something that is going to be very useful to regularly revise your topics, learn your topics. And there'll be a full subject test at the end of the subject completion. There'll be live interactive classes, doubt solving sessions, recorded sessions are available if you miss live, and PDF notes will be available at the end of each session. So this is something has to be there in place for people who are in their MBBS examinations. Okay, then there is a doubt clarification series. So this exclusive subject wise doubt resolution sessions are going to be taken up, which will be only on the Plus platform, and they start off from April 6 onwards, and this will be with the top educators. So definitely people who have not yet subscribed to Unacademy, please do so, and when you do so, please subscribe to the Plus subscription and use the code mentor. Okay, remember MENTOR is the code which you need to use to subscribe to this doubt clarification series. It's going to be very useful prior to the examinations. Then you have the Plus subscription. What is the Plus subscription? So through this Unacademy Plus subscription, you have access to both the live as well as recorded classes. You learn from India's top educators. You compete in live tests and quizzes. You study on a device of your choice, whether it's a laptop, iPad, mobile, whatever it is. And you have an access to a question bank with more than 25,000 questions which have effective explanations. Then coming to the iconic subscription. Now this iconic subscription means you have an access to Unacademy and you have an access to PrepLadder both. Okay, so in addition to all the advantages of Unacademy, with PrepLadder you have clinical and integrated essentials. You have video lectures from the Dream Team, question bank with active guidance, rapid revision, snapshots, treasures, and 2021 dream notes. These are all the toppers of Unacademy for FMGE 2021. They all have been Unacademy students, have done very well in their examinations. Also, you should know about the special classes. So if you do download the Unacademy learning app, you will also have access to the special classes. These special classes are completely free, and these special classes, they are live, interactive. There will be polls which will be set by the for the learners. You also have raise a hand feature. So through this raise a hand feature, you can talk to the educator in the class live, and you can get your doubts resolved in real time. You never miss a class because you will always be notified about it prior. Lecture notes are available at the end of each session in the PDF form, and you can access this anytime and anywhere. Yes, hi Lakshmi Kant and hi Yogesh. Mohammed, he says that I cannot sign in the app because it is not verifying a number. Okay, maybe what you can do is to completely offload the app, reload it again, okay, and then try doing it. Or if at all, if it's not happening, then you can contact the Unacademy support. They will be able to help you. Okay, now to tell you about the NEET PG High Yield Theory Revision batch. This batch will start off from March 30, will go on up to May 15. It will be for a period of 1.5 months. Okay, so this batch is very special because you're going to have 140 hours revision. You will have an interactive live class, recorded classes, PDF notes will be available. There will be 2 grand tests which will be taken up fortnightly, and question bank with more than 24,000 questions will be available. Then you have an FMGE 2022 high yield revision and MCQ batch, which also starts from March 30, will go on up to May 30. It will be for a period of 2 months. And you have this very important, now when you have to do you have to enroll into Unacademy, please be aware that there is this NEET PG end of the year sale, where you have additional 20% off on the plus and the iconic subscriptions, which will be between March 28 to March 31 2022. Okay, so you can see if you are opting for say a 6-month subscription, okay, the old price was say 20 to 500, but now it will be, including the 10% off, it will be 18,000 only. Okay, so if you're going for the iconic subscription for say 6 months, which is basically Unacademy with PrepLadder, then it would have cost you 40,000, but now it will cost you just 32,400. So when you do subscribe, please use the code MENTOR. MENTOR is the code which you need to use to get this additional 10% off. Okay, so let's now move on to the MCQs. I want this session to be very interactive, so everyone here, please do reply, please do answer. Okay, now you have a 20-year-old male who has recently returned from the Caribbean, and he presents to your clinic with a painful, sorry, just one second, this, yeah, he is presenting to you with a painful penile ulcer and painful inguinal lymphadenopathy, and a lesional swab for gram stain is showing you school of fish appearance. What is the most likely organism? So Ansaf and Lahiri, both of them say D. Anyone would like to add? Anyone? Anyone would like to differ? Anyone would let me know what is the diagnosis that we are dealing with here? Yes, Mohammed is also of the opinion it's D. Yes. So basically, yes, everyone, all of you are right. Ansaf, Lahari, Muhammad, Yogesh, all of you are right. The correct answer here is Haemophilus ducrei. Okay, and the condition that we are dealing with here is nothing but Shankroid. Okay, so Shankroid is the condition. Shankroid is a condition which is caused by the Haemophilus ducrei, and the Haemophilus ducrei on gram stain gives a typical school of fish pattern or school of fish appearance. Okay, so what are the clues that it is Shankroid? So basically, whenever you get this kind of an MCQ where they are describing you the ulcer and they are describing you the lymph node, how do you come to a conclusion what is the condition that you are dealing with? Okay, so first what you do is you look at the ulcer. Okay, now look at the ulcer, look as to whether the ulcer is painful or is it painless. That's the first step. Then after that you look at the lymph node. Okay, you look at the lymph node, look at the lymph node whether it is painful or is it painless. Again, look at the lymph node whether it is painful or it is painless. Now, tell me, what if the ulcer is painful as well as the lymph node is painful? The answer will be Shankroid. Like in this case, there was a painful ulcer with a painful lymph node, right? So the answer is Shankroid, which is caused by Haemophilus ducrei. Okay. Now, if the ulcer is painful but the lymph node is painless, then you are thinking of herpes genitalis. Okay, the erosions in herpes genitalis which happen after the rupture of the grouped vesicles, they are painful, but the lymph node that is associated with it is painless. Okay, so painful ulcer with a painless lymph node is herpes genitalis. Now, if the ulcer is painless but the lymph node is painful, then what is your diagnosis? The diagnosis is, can anyone tell me the diagnosis? What will be the diagnosis if your ulcer is painless but the lymph node is painful? Anyone? Okay, so I don't have any answers to this, but the correct answer here is lymphogranuloma venerum. So remember, the first stage of lymphogranuloma venerum, no, it's not, Mohammed, it's not syphilis, because in syphilis, even the lymph nodes are painless, right? So if there is a painful lymph node, it is lymphogranuloma venerum. Yes, Ansaf, you are right. It is lymphogranuloma venerum, right? So remember that when you have a painless lymph node in the genital stage of lymphogranuloma venerum, you have an erosion. Okay, you don't even have an ulcer. It's a painless erosion. It is transient and it is transient and it is something that may not be noticed by the patient. Okay, so the ulcer in lymphogranuloma venerum is painless but the lymph node is very painful. The enlarged lymph node may suppurate and it will form kind of an abscess which will drain, okay, with sinuses. So this is a very painful inguinal swelling which is called as a bubo, right? So painful lymph node and painless ulcer fits into lymphogranuloma venerum. If the ulcer is painless and even the lymph node is painless, then Mohammed, the correct answer will be syphilis, primary syphilis. Okay, primary syphilis will be the correct answer, or the syphilitic chancre. Got it? Now tell me, what will be the diagnosis if you have a painless ulcer but there is no lymph node? Okay, what will be the condition in which there will be a painless ulcer but no lymph node? What will be your diagnosis when there is a painless ulcer but there is no lymph node? Anyone? Yes, Lahari, you are right. It is donovanosis. Okay. So donovanosis is a condition which is caused by Klebsiella granulomatis, or it is also called as Calimatobacterium granulomatis. So Klebsiella granulomatis or Calimatobacterium granulomatis causes donovanosis. What is the other name of donovanosis? It is granuloma inguinale. Okay, granuloma inguinale is the other name for donovanosis. So remember, granuloma inguinale means there is a granulomatous swelling at the site of the lymph node. So that is why it is called as a pseudobubo. So remember, pseudobubo formation is what we expect in donovanosis. There is no actual lymphadenopathy. You have a granulomatous swelling occurring at the site of the lymph node, and hence it is called as pseudobubo. Right? So the typical ulcer in donovanosis is a painless ulcer which is having red beefy granulation tissue at the base and which bleeds on touch easily. This ulcer will be associated with the granulomatous swelling at the site of the lymph node, which is called as a pseudobubo. Okay. So when there is a painless ulcer with no lymphadenopathy, it will be called as donovanosis. Okay, now let's see the other options. They have given you herpes simplex. Herpes simplex virus 1, herpes simplex virus 2. 2 more likely than 1 causes herpes genitalis. What is the classical presentation of herpes genitalis? The classical presentation of herpes genitalis is vesicles which are grouped together over an erythematous base. These vesicles, they will rupture, they will leave behind painful erosions, and these erosions will coalesce together so as to form polycyclic borders of that large erosion. Okay, rarely it can also be caused because of HSV1. HSV1 more likely causes herpes labialis, herpes orolabialis, herpes gingivostomatitis, right? So herpes simplex virus 1 usually causes lesions above the umbilicus, and herpes simplex virus 2 usually causes lesions below the umbilicus, but they can be interchangeable as well. Now, what does Treponema pallidum cause? Treponema pallidum causes syphilis, correct? What is the clinical feature of primary shanker? How is the classical presentation of primary shanker? It's a solitary, painless, clean looking ulcer. Okay, this is very important. These descriptive words are very important for you to come to a diagnosis of what STD you are dealing with. Okay, so remember, solitary. Usually the lesions of syphilis are solitary, painless ulcer which is having a clean looking, it has a clean looking ulcer. There is no slough over it. There is just slight serous discharge. So it's a solitary, painless, clean looking ulcer, and typically it has a indurated base to it. Okay. So there is an indurated base which is very classical for a primary shanker. What are the other names of primary shanker? The other names of primary shanker are, see, shanker literally means a sore, okay, or an ulcer. The other name of primary shanker is Hunterian shanker. Okay, so Hunterian shanker, the other name of Hunterian shanker or primary shanker is hard shanker. The reason it is called as a hard shanker is because the base of the ulcer is indurated. Okay, so that was about shanker or primary syphilis. Please remember that the lymph node description is very important in syphilis. The lymph nodes in syphilis, they are painless and they have a rubbery or they have a shorty feel. Okay, so rubbery or shorty feel and a painless lymph node with a painless ulcer is something very classical for the diagnosis of primary syphilis. Then going on to the next option. The next option is chlamydia trachomatis serovars L1 to L3. Now what does chlamydia trachomatis cause? It causes lymphogranuloma venereum. So lymphogranuloma venereum, as I mentioned, it starts with the stage of genital involvement where there is a transient painless ulceration or erosion which goes unnoticed by the patient. Now, this particular organism, that is Chlamydia trachomatis serovars L1, L2, L3, it has a very specific affinity for the lymphatics. So, it is going to cause inflammation of the lymphatics. That is called as lymphangitis. Now, because there is inflammation of the lymphatics or there is lymphangitis, there is occlusion of the flow of lymph, right? So that is why there is a lymphadenopathy. Okay, there is enlargement of the lymph node. Okay, and then this lymph, it's a very good medium for the bacteria to proliferate. So that is why there is secondary bacterial infection in the inflamed lymph nodes, in enlarged lymph nodes, and it forms a huge inguinal swelling. So this painful, very very painful inguinal swelling in LGV is called as a bubo. Okay, now this bubo sometimes may become very tense and it may drain out onto the skin in the form of sinuses. Okay, so remember that in LGV their ulcer is painless but the lymph node is very very painful. Now please remember that there is a very important sign that is seen in LGV and that is called as the groove sign. So what is this groove sign in LGV? In groove sign, you have a lymph node swelling which is above the inguinal ligament and below the inguinal ligament. Okay, and in between the inguinal ligament looks like a groove. Okay, so in between the two buboes, when you have the inguinal ligament forming a groove, it is called as the groove sign of Greenblatt. Okay, so groove sign of Greenblatt, please remember, is seen in lymphogranuloma venereum. Okay, then going on to the answer here, which is Haemophilus ducrei causing Shankroid. So what is the characteristic of Shankroid? Shankroid, please remember, it is a little different from, I will just explain to you here in a different slide so it's easy. Yeah, so here if you see the difference, if you see the difference between chancre, which is caused by syphilis, and chancroid, this is something very very important for you to remember. Chancre or a primary chancre is caused by Treponema pallidum. Okay, it is the primary chancre of syphilis. So it is caused by Treponema pallidum, while chancroid is caused by, it is caused by Haemophilus ducrei. Okay. Now, Treponema pallidum causing primary chancre is usually solitary. Okay, while chancres can be multiple. Apart from that, the primary chancre, as I mentioned, it's a clean looking ulcer. Okay, clean looking ulcer, while in chancroid, it's a dirty looking ulcer because it is covered with slough, no? So it's a dirty looking ulcer. The base of primary chancre is indurated. Okay, and that is why it is also called as hard chancre. Okay, while in chancroid the base is soft. Okay, okay, it is non-indurated and that is why it is also called as a soft sore or it is also called as soft chancre. Okay. Now, the other point of difference is that very importantly, the primary chancre is painless, while in Shankroid, the ulcer is exquisitely painful. Then going on to lymph nodes, the lymph nodes in primary syphilis have a shorty or they have a rubbery consistency and they are painless. While in Shankroid, it is called as an inflammatory bubo. Okay, it's called as an inflammatory bubo, which is painful and it has it is not having a shorty or a rubbery feel. It will be of a soft to firm consistency. Okay. Now, how do you treat primary chancre? The primary chancre of syphilis is treated with injection benzathine penicillin. Okay, injection benzathine penicillin, which is given in the dose of 2.4 million units intramuscularly. IM, that is intramuscularly, stat means a single dose, and it has to be done after a test dose, right? While for Shankroid, what will be the treatment? Shankroid will be treated with azithromycin, 1 gram, single dose. Okay. So that was how you differentiate between a primary chancre, that is syphilitic chancre, versus a chancroid. Okay. Now let's go on to the next question. Now, second question. An infectious pustular dermatosis develops in a goat farmer. Look at the occupation. He is a goat farmer. The causative organism is known to be very sturdy and survives many months in the cold winter. Okay, so it's an infectious pustular dermatitis and there is localized lymphadenopathy and crusting. What is the most likely organism here? Anyone? Anyone can tell me the answer here? What do you think is the answer? No answers? Goat farmer. The clues are that it's a pustular dermatosis has developed in a goat farmer. Okay, and there is associated localized lymphadenopathy, and this particular organism is very sturdy and survives many months in the cold winter. Anyone? No, Anjum, it's not A. See, Sporothrix shanki causes sporotrichosis, and sporotrichosis is caused by Sporothrix shanki, which is going to survive on fauna, okay, like plants, thorns, leaves. So, Sporothrix shanki, which causes sporotrichosis, the occupation is generally going to be either a farmer or he is going to be a florist or he is going to be a gardener. The occupation of the patient is very important clue. Okay, so for sporotrichosis, usually the patient is a farmer, florist, or a gardener. Okay, here the patient is a goat farmer. No, Deepti Mansoor, it's not Franxiella tularensis. Franxiella tularensis is found on the rabbits. I think if you come to the conclusion as to what the diagnosis is, you will be able to know the causative organism. So basically, this infectious pustular dermatosis was nothing but ORF. Okay, and ORF, as you know, is caused by the parapox virus. So the correct answer here is C. Yogesh, you are right. It is parapox virus causing nothing but ORF. Okay, so it is the other name for ORF. This is very important. The other name for ORF is ecthyma contagiosum or contagious pustular dermatosis. So ecthyma contagiosum or contagious pustular dermatosis is ORF. It is transmitted by a parapox virus. Remember, ORF is caused by a parapox virus which is present in the sheep, it is present in the goat and the reindeer. It is a self-limiting condition with an excellent prognosis, and hence the treatment is only supportive. So please remember the other names. These are extremely important. Infectious pustular dermatitis, also called as ORF, also called as ecthyma contagiosum. Okay. Now can someone tell me, ecthyma contagiosum is ORF. What is the causative organism of ecthyma gangrenosum? Can someone tell me what is the causative organism of ecthyma gangrenosum? Can someone tell me? Ecthyma gangrenosum is caused by anyone? Because these terms can be confusing. Ecthyma contagiosum is ORF, which is infectious pustular dermatosis. Ecthyma gangrenosum is caused by? No, it is not one of the options. Yes, Ansaf, you are right. Ecthyma gangrenosum, remember, is caused by Pseudomonas aeruginosa. Okay, so Pseudomonas aeruginosa causes ecthyma gangrenosum. Now tell me, what is the causative organism of molluscum contagiosum? Okay, I'm asking you, what is the causative organism of molluscum contagiosum? What is the causative organism of molluscum contagiosum? Pox virus. Very good, Mansoor. It is pox virus. It is also falls into the category of molluscum contagiosum virus 1 and 2. Okay. So molluscum contagiosum is caused by the pox virus. So do not confuse. Ecthyma contagiosum is different. Ecthyma contagiosum is nothing but ORF. Ecthyma gangrenosum is different, which is basically caused by Pseudomonas aeruginosa. Molluscum contagiosum is different, which is caused by a pox virus. Now tell me, what is ecthyma caused by? I am not asking you ecthyma gangrenosum. I am just asking you ecthyma. What is ecthyma more commonly caused by? What is ecthyma caused by? Yes. Sanjay, you are right. It is streptococcal infection. So more likely it is streptococci, less likely it is staphylococci. Okay, so ecthyma is primarily a streptococcal infection, can sometimes be caused by staph as well. Okay, so do not confuse. Ecthyma is caused by streptococci or staphylococci. Ecthyma contagiosum is nothing but ORF, which is caused by parapox virus. Ecthyma gangrenosum is caused by Pseudomonas aeruginosa. Okay. Yes. So I have already discussed Sporothrix shanki. Now Sporothrix shanki, it causes porotrichosis. It is a fungal infection which is caused by inoculation via rose thorn. So that is why this condition is also called as rose gardener's disease. So it is caused by rose gardener's disease. Now tell me, what are the bodies that you get in the histopathology of sporotrichosis? What are the bodies that are appreciated in the histopathology of sporotrichosis? Anyone? Yes, Sanjay, you are right. They are asteroid bodies. Very good, Robin Kumar. They are asteroid bodies. So, asteroid bodies are eosinophilic bodies which are seen in the histopathology of sporotrichosis. Yes, Lahari, you are right. So remember, Sporothrix shanki is going to be present on the stem, the thorns, okay, the leaves, okay, and that is why the people who get sporotrichosis are people who are farmers, gardeners, or florists. And typically, please remember about sporotrichosis that you have a lymphatic spread, okay. Okay, so that is why there is a variant of sporotrichosis which is called as lymphocutaneous variant of sporotrichosis, and this manifests as nodulo-ulcerative lesions which are going to be in a linear fashion. So remember, linear lesions, linear nodulo-ulcerative lesions are very classically seen in sporotrichosis. So sometimes they may even show you an image. Okay, this can be important from the image based MCQ as well, that you have multiple nodulo-ulcerative lesions which are occurring on the linear fashion in a forearm. Okay, and the patient is a florist, farmer, or a gardener, gives a history of thorn prick followed by which he noticed these kind of lesions. Okay, so the answer will be sporotrichosis. Remember, sporotrichosis can also involve the lung. Okay, now tell me, what is the treatment of choice of sporotrichosis? What is the treatment of choice in sporotrichosis? Anyone? What is the treatment of choice in sporotrichosis? Yes, Sanjay, you are right. It is itraconazole. Okay. So the drug of choice in sporotrichosis is itraconazole. Avinash, amphotericin is not something that we use in sporotrichosis. Amphotericin B it's more given for invasive fungal infections, okay, which are disseminated. So because of its high toxic potential, amphotericin is usually not preferred as the first choice. Okay, and the answer here is itraconazole. Now, next option was tularemia. Tularemia, I mean, they have mentioned in the option Franxiella tularensis. So this Franxiella tularensis, it is going to cause tularemia. Okay, so tularemia is associated with rabbit contact, and it is caused by a bacterium Franxiella tularensis. Okay, so Franxiella tularensis is associated with rabbit contact and causes tularemia. Then the next option was erysipelathrix rhizopathiae. Erysipelathrix rhizopathiae is caused by, it is going to cause erysipeloid. Okay, it causes erysipeloid, which is a bacterium which is transmitted via pigs or fish. Okay, so erysipelathrix rhizopathiae causes erysipeloid, which manifests as a finger which has become erythematous and swollen. Okay, that is the classical clinical presentation of erysipeloid, and it is transmitted via pigs or fish. Orthopox viruses can cause vaccinia, smallpox or cowpox. Okay, so remember orf is caused by parapox. Sporothrix shanki causes porotrichosis. Franxiella tularensis causes tularemia. Erysipelotrix rhizopathiae causes erysipeloid. Orthopox can be associated with vaccinia, smallpox or cowpox. Okay. So remember the contacts. Okay. Like for example in Sporothrix shanki it will be a thorn or a rose handler. In Franxiella, it will be a rabbit. Parapox, it will be goat, sheep. Okay. In Erysipelotrix, it will be pig or fish. And in Orthopox virus, it can be anywhere. Okay. So now let's go to the next question. Which of the following is false? Okay, they have asked you what is false regarding actinomycosis. Poor dental hygiene is a risk factor. It most often develops on the jawline. It is caused by anaerobic filamentous gram-negative bacterium. Drainage of sulfur-like granules is characteristic. The treatment of choice is penicillin. What do you think is the answer? They have asked you what is false. Ansaf says it's C. Anyone? Okay, Anjum says it's E. Avinash says it's C. Okay, the correct answer here is C. Okay, it is a gram positive anaerobic bacterium. It is not a gram negative. So, yes, Ansaf, you were right. Okay, so please remember that actinomycosis is caused by gram positive bacterium. Rest of the statements are all correct. That poor dental hygiene is a risk factor. It is most often developing on the jawline. It is caused by anaerobic filamentous gram positive bacterium. There are drainage of yellow sulfur-like granules is characteristic. The treatment of choice is penicillin. So yes, treatment of choice is penicillin. For people who have answered E, just let's clarify. Actinomycosis is different. Actinomycetoma is different. Okay. Do not confuse these two terms. Actinomycosis is what is caused by these actinomyces. It is caused by this actinomyces israeli. Okay, which is an anaerobic filamentous gram positive bacterium that is a part of the normal oral flora. Okay, while actinomycetoma, it can be caused by organisms like nocardia. Commonly it is nocardial infection, nocardia, actinomycetes. Okay, and nocardia, I don't know, Ayush, what is CSIR? Please let me know what is CSIR. I am not aware of it. So, nocardia, actinomycetes causes actinomycetoma, and the treatment of actinomycetoma is not penicillin like in actinomycosis. You can treat it with the Welch regimen. Okay, there are modified Welch regimen, and the Welsh regimen. So this Welsh regimen is again an MCQ, an important MCQ. Welsh regimen is where you administer injectable amikacin. Along with it, you give oral cotrimoxazole. Okay. So Welsh regimen is where you give amikacin with cotrimoxazole. You can sometimes also give amoxicillin, clavulanic acid. Okay, so the treatment for actinomycetoma is different, and for actinomycosis is different. Fine. Now let's go to the next question. You have a patient who is presenting with yellowish brown colored concretions on the axillary hair shafts bilaterally. Which of the following non-medical management advice will you ask the patient to do to improve his condition? Avoidance of shaving, switching to unscented, fragrance-free deodorant, avoiding deodorant, avoid participation in athletics. What will you tell him? Okay, so I have Ansaf and Anjum answering B. Okay, so yes, both of you are right. The correct answer here is shaving, and the condition that we are dealing with is trichomycosis axillaris. Okay, please remember trichomycosis axillaris is a misnomer. Okay, it is a misnomer. Tricho means hair. Mycosis means a fungal infection. Axillaris because it is present in the axilla. So it is not a fungal infection of the axillary hair. Mycosis is a misnomer. It is actually a Corynebacterium infection. Can you tell me which Corynebacterium causes trichomycosis axillary? Which Corynebacterium causes trichomycosis axillaris? Anyone? चलो जिसने जवाब अगर सही दिया है अंसाफ अंजुम अविनाश टेल मी व्हाट इज द आंसर इट इज Corynebacterium tenuis. Okay, remember Corynebacterium tenuis causes trichomycosis axillaris. It is not a fungal infection. It is caused by Corynebacterium tenuis and it presents as yellowish colored nodules on the hair shaft. Okay, yellowish colored nodules are seen on the hair shaft. Okay, Lahari, can you tell me what does Corynebacterium minutissimum cause? Corynebacterium minutissimum does not cause trichomycosis axillaris. Can you tell me which condition does Corynebacterium minutissimum? Corynebacterium minutissimum causes anyone? Yes, very good, Ansaf. It causes erythrasma. Okay, so it causes erythrasma. So Corynebacterium minutissimum causes erythrasma. Corynebacterium tenuis causes trichomycosis axillaris. Then you have Corynebacterium. Then you have the Micrococcus sedentarius, which is also a variation of Corynebacterium. Micrococcus sedentarius, it causes pitted keratolysis. So remember, These are the three conditions which are caused by Cornybacteria. So Cornybacteria minutissimum causes erythrasma, Cornybacterium tenuis causes trichomycosis axillaris, and Micrococcus chytococcus sedentarius species causes pitted keratolysis. Okay, so apart from this, let me elaborate via yes. So when you have a patient who is presenting to you with nodules over the hair shaft, okay, if there are nodules on the scalp hair or there can be nodules in the axillary hair. Nodules are on the scalp hair if they are white in color or they can be black in color. Axillary hair nodules if they are yellow in color. So black colored nodules on the scalp hair, you will think of your diagnosis as white piedra. If there are black colored nodules on the scalp hair, you will think of black piedra. If there are yellowish colored nodules on the axillary hair, you will think of trichomycosis axillaris. Now, white piedra is caused by, anyone can tell me what is the cause of organism of white piedra? What is the cause of organism of white piedra? It is caused by trichosporon beigeli. Okay, so trichosporon beigeli causes white piedra. Black piedra is caused by piedra hortae. Okay, so piedra hortae causes black piedra and trichomycosis axillaris is caused by Cornybacterium tenuis. So importantly, please remember this is the differential diagnosis of nodules seen over the hair shaft. Okay, these are true nodules. Otherwise, you can even see multiple other structures on the hair shaft. You will be able to see dandruff flakes on the hair shaft. You will be able to see nits on the hair shaft. Okay, so dandruff flakes and nits, how do you differentiate? Dandruff flakes, if you try and flick off, they will be easily flicked off of the hair. While nits, you will not be able to flick it off. You will have to remove the nit by pulling it along the hair shaft. Right? So that's how you differentiate between dandruff and nits. Okay. So whenever you see a patient who is presenting with nodules on the hair shaft, on the scalp, the possibilities can be white piedra, black piedra, dandruff, nits. Okay, so these are the things how you will differentiate. So the treatment of trichomycosis axillaris, the best treatment is that you shave off the hair in that area, right? Uh, The treatment options include shaving. You can give benzyl peroxide gel and topical erythromycin, clindamycin can also be given. Okay, so that was about trichomycosis axillaris. Now let's go to the last question that we'll be able to take up today. You have a 7-year-old boy who presents to your clinic with his mother, who tells you that the boy is having multiple days of flu-like symptoms. So he's a 7-year-old boy and his mother is telling you that he is having multiple days flu-like symptoms and the new rash has now come up, which is asymptomatic. On examination, you notice a 5 centimeter erythematous annular patch on his thigh. Both the boy and his mother deny a history of tick or other insect bites. What is the best treatment? None. Doxycycline, IV ceftriaxone, trimethoprim, sulfamethoxazole or amoxicillin. What will you give the patient? Anyone? So first of all, come to a diagnosis. So you will know what treatment you can give. See, the clues are that there are flu-like symptoms, and then on examination you see that there is a 5 centimeter erythematous annular patch on the thigh. Okay, there is history of what? There is no history of any tick or other insect bites. Yes, Ansaf, you are right. You are dealing with limes. So basically what you are dealing with here is nothing but erythema chronicum migrans. This is the condition that you are dealing with, which is erythema chronicum migrans, which is caused by yes, it is caused by Borrelia burgdorferi, right? So okay, Avinash says it's doxy, but doxy is incorrect. Why is doxy incorrect? In this question, please read the question carefully. They are telling you that this patient is 7 years old. At the age of 7 years old, you cannot give doxycycline. Okay, you cannot give doxycycline. That's because it can cause staining, permanent staining of the teeth, right? So you preferably give doxycycline only above 9 years of age. So when you have to give doxycycline, um, um, the child has to be above 9 years of age, but this child is 7-year-old. So then what will you change the answer to? What will you give? Kashish Jain, there may not be a history of tick bite in patients having erythema chronicum migrans necessarily. The history is not something that will give you the diagnosis. Okay? It is the clinical examination having this targetoid lesion on the thigh which is going to help you with the diagnosis. No, Anjum, it's not IV ceftriaxone. The correct answer here is E, that is amoxicillin. Okay, it is amoxicillin. So it is a classical presentation of early localized Lyme disease which commonly does not have a positive history of a tick bite. The diagnosis can be made clinically when the erythema chronicum migrans, which presents as an expanding annular erythematous patch at the site of the tick bite, is noted on examination, and this is pathognomic. As such, starting antibiotic treatment is warranted to prevent the progression of the disease into early disseminated or chronic stages. In pregnant women and in children who are less than 8 years of age, amoxicillin can be used between 14 to 21 days due to concern for potential bone and tooth abnormalities induced by tetracycline group of antibiotics. Okay, Lyme's disease is not self-resolving. Although erythema chronicum migrans usually disappears within 4 weeks without treatment and requires antibiotic treatment to prevent the disease progression and its associated morbidity. The other choices are okay. So the correct answer here was amoxicillin. It would have been doxycycline if the child was older. Okay. So I think that's the time we have today. If you have any questions regarding whatever we learned today, please let me know. Are there any questions, any doubts? Or we can call it a day. I will meet you tomorrow same time between 9:30 to 10:30. Okay. So tomorrow again there will be a YouTube session and we will continue with this Mixed Bags of MCQs. Okay, so do join an academy and do study well. Thank you very much, everyone, for a patient hearing, active participation.